So hello everybody. I'd like to welcome you to the Grand Rounds. Just waiting for these slides to catch up. So welcome to the worldwide webinar, Grand Rounds. Today we have the most important people is the audience. And what we would like you to do is to use the comment section on Facebook and YouTube to type your questions. What we will do is throughout the presentations and the discussion, we'll try and answer as many questions as possible. But don't worry, don't stop posting your questions. Any unanswered questions will be compiled as a PDF by all of the experts and then uploaded onto the WSPOS website. We also have Mentimeter questions. So go to www.menti.com. The Menti passcode is 2394971. And you can also use the QR code. With regards to the questions, answer all of them from 1 to 11, and then leave question 12 and 13 until the end of the presentation. Today we have a fantastic panel and some great speakers. Our first panel member is Dr. Venkat. Dr. Venkat did his ophthalmology residency and fellowship in strabismus and neuro-ophthalmology at the RP Center in New Delhi. He then completed his prestigious APOS fellowship in pediatric ophthalmology, strabismus, under the tutelage of the world-renowned Professor Eugene Haverston from Indiana. Amazingly, he started and headed the Department of Ophthalmology and Strabismus and Neuro-Ophthalmology at LV Prasada in 1998 and remained there until 2006. He's presently the director of the Shreya Eye Care Center in Hyderabad. Welcome.
Thank you.
We're also very excited to have Claudia Paulo, who did a residency and fellowship in Buenos Aires, Argentina. I think it was her mentor, Dr. Melek, who inspired her to move into the field of strabismus in children. She currently works at the Pinero Hospital, and she's no stranger to webinars or teaching at any level. She is the co-director of the annual strabismus course at the Pinero Hospital and is a member of the board of directors of the Argentine Center for Strabismus. Claudia, welcome.
Thank you.
We also have Dr. Parth Shah. He's currently working at the Sydney Children's Hospital, the Prince of Wales Hospital, and the Sunderland Hospital. He completed his ophthalmology training through the Sydney Children's and Prince of Wales Hospital in Sydney, Australia. He is dual trained and has 2 pediatric fellowships, one from Birmingham Children's Hospital in the United Kingdom, and the other at UPMC Children's Hospital of Pittsburgh. Parth is also a clinical lecturer at the University of Sydney, where his research includes not only clinical, but digital health. And in the bottom right-hand side, you can see a number of the apps that Parth has developed. I'm also excited to introduce Ravi Purohit. He's a craniofacial and an ROP specialist orthoptist at the University of Oxford. He has an MSc in neuroscience and currently preparing to defend his thesis in the development of optic nerve, head, and foveation strategies in infantile nystagmus. He professionally has an interest in nystagmus, ROP, craniosynostosis, with an emphasis on imaging. And Ravi is going to be my co-moderator today. What I'd like to do now is to hand over to Ravi to introduce the remaining panel.
Hello, everyone. So I'd like to welcome Alki. So Alki is qualified in, he completed his degree in biomedical physics. He worked at the National Hospital moving
Excuse me,
over.
sir, your voice is not coming properly. Apologize for that. Your voice is not coming properly, sir.
Okay, I apologize. So I'll just carry on.
Where are we up to?
Sorry?
Where are we up to? We on to the next speaker?
Yep. So can you hear me now? Is that better?
That's a lot better, Ravi.
Okay, so the next panel member is Dr. Maria Correa Navarro. She's trained as a pediatric ophthalmologist. She's doing she has done a pediatric fellowship and at university. Oxford University. Birmingham and Cheltenham with the subspecialty interest. Dr. Asmina Matafasi. She's an associate professor at the Associate Professor of Pediatric at University in Thessaloniki in Greece. She trained in Louisiana, Switzerland, and in London. She did a pediatric fellowship at Great Ormond Street in London. And Dr. Savleen Kaur. She is a graduation and post-graduation in ophthalmology from Delhi University, trained at the Advanced Eye Center, PGI in Chandigarh, India, under Dr. Jaspreet Sukija. And now I'll introduce Dr. Savleen's talk. Savleen.
Okay, Savleen, so if you can share your screen now, thank you.
Thank you, Dr. Ravi, for that generous introduction. And hello, everyone, and thank you for joining with us. As I share my screen today, I would like to acknowledge my mentor, Dr. Jaspreet, for intellectual inputs on this case. I wish to share the story of a 43-year male who presented with a double vision maximally in the right gaze. Ocular examination revealed that he had a best corrected visual acuity of 20 by 20 in both eyes. Anterior segment was within normal limits. He adopted a right head tilt as a posture and was fixing mostly with the right eye. He had a left hypertropia, which increased in the right gaze and the left head tilt. Extraocular movements in 9 gazes revealed that he had a left hypertropia. He also had an over elevation in adduction, in dextroelevation as well as in dextroversion, suggestive of an inferior oblique overaction in the left eye. Depression showed minimal superior oblique underaction. Measurements done with a prism cover test at 6 meters revealed a 4 prism diopter left hypertropia in the primary gaze, increasing to 12 prism diopter in the right gazes. In the up gazes, the hypertropia measured around 8 prism diopters and also increased on the left head tilt. Posterior segment examination, mainly done to document the torsion, revealed an extorsion of 15 degrees, which was evident in the right eye. At this point of time, he was diagnosed as a case of left decompensated congenital superior oblique palsy. He was treated with a left inferior oblique anteriorization. The procedure was done under peribulbar anesthesia when the inferior oblique was inserted nearly 1 millimeter behind the insertion of the inferior rectus, the temporal insertion of the inferior rectus, and the posterior fibers of the inferior oblique were inserted within 2 millimeters of the anterior insertion. After the surgery, his primary gaze diplopia and diplopia in dextroversion had improved. He was doing fine for 6 months when he started to develop an up gaze diplopia. The COVID-19 lockdown had opened and he had resumed his job as a carpenter So he realized that he had diplopia in upgaze, which he did not notice before, that incapacitated him while working. We called him for another examination 6 months after the first surgery, which now revealed that he did not have entropia in the primary gaze. He did not have diplopia in the primary gaze. However, on prolonged cover testing, he did reveal a left hyperphoria in the primary gaze. Further version testing revealed that he had a limitation in elevation of the operated left eye. He also had a depression of the inferior oblique in the operated eye, suggestive of mimicking a right inferior oblique overaction. Depression was essentially normal and there was no tropia in the primary gaze. Measurements at this time was 8 prism diopter of right hypertropia in all the up gazes. Rest of the gazes, he was not having any diplopia or any tropia. Posterior segment examination again in the right eye, we had an extorsion which had lessened now to 10 degrees. To summarize, he was a left decompensated superior oblique palsy to begin with, treated with a left inferior oblique anteriorization, and developed an upgaze diplopia 6 months later. Examination findings at this point of time was reversal of hypertropia along with a limited elevation of the operated inferior oblique. At this point of time, I would like to raise the first question to the panel as to what do they think the diagnosis is. Is it a masked bilateral superior oblique palsy? Is it an anti-elevation syndrome or something that we missed?
Sableen, thank you very much. A lot of information and some great slides. So what I'd like to do now is to pass over to, maybe we'll start with Dr. Venkat to make some comments about the first question.
Yeah, thank you, Dr. Alki, and thank you, Dr. Sableen, for the nice presentation. Yeah, so in a situation, in this patient had to start with a very small hypertropia, less than 5% diopters, and his inferior oblique overaction probably was 1 plus, or maybe 1 to 2 plus. It was not very evident on the photograph. But if you're making a diagnosis of, a decompensated left superior oblique palsy with small deviation and symptomatic, it doesn't call for a diagnosis of a congenital palsy, of course. They tend to have more vertical fusional amplitudes. And as you uncover their fusion, you tend to develop more amount of hypertropia, which probably we did not develop here. And the only thing, other thing was, to have a torsion in the other eye, which was a paradox thing. But sometimes you can also have a torsion, in the contralateral eye rather than the affected eye. But a torsion of 15 degrees, that's too much of a torsion. If you have a 15-degree torsion, extorsion, it generally goes by bilateral superior oblique palsy. Whether this patient had a torsional diplopia or a vertical diplopia, that's one thing which we need to look at it. And he didn't have a V pattern. If it's a bilateral superior oblique palsy, let's say if it could have been a masked bilateral, he didn't have a V pattern. Typically, you tend to have V pattern, and you tend to have hypertropia alternating on the side gazes or tilting to the on the Wilczowski's head tilt is to either to the left or the right side. So that's one possibility is there because of the excicular torsion being noted in the other eye, and that to a 15-degree excicular torsion, which is kind of very paradoxical here. So sometimes you can get a masked bilateral palsy, but you need to go and look back and see whether it was truly a bilateral superior oblique or not.
So Dr. Palak, are you able to comment on how we measure torsion?
Yes, I have a question for you, Sableen. Did the patient a neurological evaluation at the first control?
Thank you, Dr. Apollo. We diagnosed him as a case of congenital superior oblique palsy, mainly because he had old photographs showing the torticollis. He had an objective torsion, which was much more than the subjective torsion, as well as large vertical fusional amplitudes. He was referred to us from neurology actually, and he was evaluated because he suddenly developed diplopia. We did not further pursue the neurological evaluation. He did have an MRI, which was reported to be normal, because we were sure that because of the old photographs, the objective torsion not corresponding with the subjective torsion that the patient have, objective torsion being much more, and the large vertical fusional amplitudes, we diagnosed him as a congenital superior oblique palsy. We do see that, to my experience, as well as literature quotes, that primary position hypertropia in a case of congenital superior oblique palsy might range from something like 2 to 25 prism diopter. So we kept that possibility in mind, that he might have, a small hypertropia in the primary gaze, but not deferring us, not make a diagnosis of a congenital superior oblique palsy.
It's very interesting to your case, Sabine, because the extorsion of the right eye would be an ocular tilt reaction, because the hypotropic eye is in extorsion.
Correct.
And what do you think about this?
I completely agree with you. Torsion in an eye with superior oblique palsy might be seen paradoxically in the other eye, but we have enough evidence to say that we have to do fundus photography of both eyes in such cases, because we might see it in the other eye. But the head tilt test was quite positive, and so it was not in favor of an OTR, and hence we were sticking on to the diagnosis of congenital superior oblique palsy, and that's why the surgery.
Okay, just before we go to, I think Dr. Venkat had a comment. As always, WSPOS is a global.
Yeah, Sablina, did you measure? Did he have a torsional double vision or diplopia and double maddox rod, or was it just a vertical thing?
He was not complaining of torsional
He was not.
diplopia.
He wasn't. So this was mostly the objective torsion.
Yes.
Objective torsion.
Objective torsion was much more than the subjective torsion.
Correct.
Yes.
Yeah. So okay. Yeah.
Okay, so just before we go to your next question, Celine, I just wanted to share with everybody that there's people from South Africa, Nigeria, Australia, UK, Greece, Canada, Russia, Saudi Arabia, many countries being logged in and listening to this conversation. So Celine, carry on to your next question.
Thank you. So due to this depression that we see in abduction, and because there was no V pattern, there was extorsion less than 20 degree, there was no chin down posture and no reversal on the head tilt test, we diagnosed him as a case of anti-elevation, because there was a limitation in elevation of the operated left eye, mainly on looking in the adduction as well as the abduction. And at this point, if it was anti-elevation, I would like to ask the panel again that what do you think are the factors that cause overcorrection or anti-elevation after surgery for superior oblique palsy? Do you choose the inferior oblique weakening surgery depending on the primary position hypertropia, the torsion, or the contralateral incompetence? Or how do you place the posterior fibers when you are operating on the inferior oblique?
Okay, so I just want to remind everybody before we ask that question to Dr. Paolo, the Menti code again is 2394971. So Dr. Paolo, can we have your comments? What's the cause?
Yes, thank you. Sabine, in my opinion, your patient has not a complete anti-elevation syndrome because he has not a hypotropic in primary position. But did you perform FDT before surgery?
After we diagnosed him as anti-elevation, we did do an FDT before we diagnosed him, in fact. A force-suction testing for elevation in adduction as well as abduction was free.
Okay.
For the inferior oblique.
Okay. I think this is a normal result of limitation in elevation on abduction when the anterior transposition of the inferior oblique is performed unilaterally. This is my opinion, because the patient has a mild hypertropia in the primary position. He is not hypotropia. So maybe the unilateral perform of this technique can be produce these clinical pictures.
Dr. Venkat,
yeah, I think Yeah, I think I fully agree with Claudia Paulo about what the procedure was. I think because of the smaller hyperdeviation, like less than 5% diopters in the primary position and going up to 10 to 12 in the side gaze, doing an anterior transposition of inferior oblique is a little stronger procedure, and you're anteriorizing the fibers. So you're creating some amount of anti-elevation would definitely be created, though you may not have hypotropia in the primary position, but you have limitation of elevation into adduction. But typically, anti-elevation, you should have limitation of elevation in abduction, not into adduction. Typical anti-elevation, because of the fibers which are the posterior fibers and the anteriorized ones, as the eye elevates into abduction, it acts like a tether, the fibrovascular bundle, which acts like an ancillary functional origin. So it tends to kind of have mechanical tether and has more in abduction rather than in adduction. This patient has more in adduction into the field of weakened inferior oblique. So that's how, it's not a typical anti-elevation. And moreover, if you have an anti-elevation like that, you tend to have a contralateral, 6 months down the road, you tend to have the contralateral pseudo-inferior oblique overaction because of a tether there. But having said that, sometimes the forced suction test, would be normal in this because it's a clean surgery. You will not have a forced suction test, positive in this unless there has been some kind of a, problem with the posterior tenons and things like that, where you have additions there. But typically, this is paradoxical because if you have anti-elevation, it should be more into abduction rather than into adduction. And secondly, I think probably, a milder weakening procedure of the inferior oblique would have wouldn't have resulted in, having a problem where the patient has now double vision looking into the field of up gaze because of the primary position deviation being small.
Okay, thank you, Dr. Venkat. I'd like just to say hello to all the people who've joined from Mexico, Colombia, Argentina, and Malaysia. So Savleen, I think you have one more question before the rest of your talk.
I would just like to ask the panel if the inferior oblique weakening surgery that you choose depends on the primary position hypertropia when you do it, to your experience, or do you tether it according to the contralateral incompetence from primary to the dextroversion, for example, in this patient? And because inferior oblique surgery is known to be self-titrating, and anteriorization has been described successfully for even smaller gaze primary position hypertropias. So do you tether it according to the primary position hypertropia or according to the incompetence, like in this patient?
So Dr. Venkat, if we can start.
Yeah, sadly, yeah, that's right. But the problem is here is you're doing a unilateral anterior transposition, So that's definitely going to cause some amount of anti-elevation. So considering that, definitely the primary position deviation does matter a lot. But I wouldn't really do typically a weakening procedure like anterior transposition for a hypertropia. I would rather do just an inferior oblique a weakening procedure, which in my hands I do myectomy. And it just self-corrects, as you rightly said. Up to 15 prism diopters, you could actually get what you want by doing one oblique muscle surgery, inferior oblique myectomy or inferior oblique recession, whichever way you are doing it, you could actually do and get away with it and get good result. But if you do, let's say you do an anterior transposition, like what we have done here, then you will tend to have a problem like this. You may not have hypertropia post-op, but you tend to have, mild limitation into the field of up gaze, creating an incompetence there. So that's what I feel that, So.
Okay. And do you think that torsion would also guide us, because larger torsions, and then would you choose your surgery, the inferior oblique surgery, according to the torsion? Because this patient had a large amount of torsion. So,
yeah, but he was not having a subjective torsion, So if it's a bilateral superior oblique palsy, and he's got a significant amount of torsion of 15 degree, then that's your surgery will change totally, right? So here he doesn't have much of torsion there at all, subjectively. Okay, so. Sometimes,
it could be both a mass component and an anti-elevation. Could it be that?
You mean to say after the surgery now?
Yes. like it was a masked superior oblique and now coupled with an anti-elevation? Because
Yeah,
anti-elevations is very common. I mean, not very, very common, but say to the extent of 8 to 16%, but they are
Right.
rarely symptomatic.
Yeah.
So the mask component might have caused the symptoms.
Yes, Sablin, but the thing here is my real way, what I look at is, here you have an elevation. There's no limitation of elevation maximum in abduction. It's in adduction. An anti-elevation typically would cause limitation of elevation in abduction into the lever elevation, but he has a problem into the dextro elevation, right? So there, the anti-elevation thing really doesn't come here. Typically the anti-elevation would be into elevation into abduction, ABD abduction, not into adduction. So this, and then that would cause a contralateral inferior oblique overaction paradoxically. I mean, it's basically a pseudo overaction. So let's say if you have to kind of correct it, either you go back and undo what you have done, basically you undo the anterior transposition and then you recess the inferior oblique further back by 4 millimeters or so, and you can get away with that's one option. Now, other option would be, let's say if it's a masked bilateral palsy, okay, and there's a masked bilateral palsy and the right inferior oblique has started overacting, then you have to do the same procedure on the right eye. You have to match it now. You have done one inferior oblique anterior transposition, so you do other eye inferior oblique anterior transposition and match them both. Especially when you did a unilateral, then you have a masked bilateral and the other eye showing a superior oblique palsy now. So you do the same procedure on the other eye and then match it. But if it's purely an anti-elevation syndrome, then you have to go back and undo the same thing at the eye which we have done. Either you do a myectomy of the anterior transverse muscle, or you further recess the anterior transverse muscle so that you take away the tether and then you get the thing corrected. That's how I would look at it.
Okay, Sableen, I've got two questions. One is to Ravi about, as an orthoptist, is how often does he see anti-elevation? And then I'll have another question for the panel as a group. So Ravi, how often do you see anti-elevation?
We see that much of. Usually when we see cases like this, it's, whiplash injuries and bilateral fourth nerve palsies. Occasionally, we'd see some odd presentation of a fourth, but I'd say anti-elevation syndrome, quite rare.
And the next one's for the panel in the whole, and I'll start with Dr. Shah. Have you ever caused anti-elevation?
I think, I think I do anterior transposition surgery for large angles in primary position, as well as for deliberately for things like a DVD. And I certainly have one patient who was a child who did have what looked like a anti-elevation syndrome after anterior transposition of the inferior oblique muscle. So at least one patient who had a definite anti-elevation, but in relation to the number of inferior oblique surgeries performed, it's probably quite uncommon, I would say.
Okay. Dr. Guiaro?
I am lucky still because I am a fellow, so I am usually supervised. So the calculations for the surgeries are usually discussed with my mentors, and therefore I will be able to give an update maybe in a couple of years.
Okay. We do have a question through YouTube at the moment, and maybe Dr. Venkat can answer it for me. It says, what should be considered not to create anti-elevations?
Okay, so the most important thing is when you're putting where you're going to put the inferior oblique, and how far anterior you're going to put the inferior oblique, and how much spread out the inferior oblique is at the insertion of the inferior rectus. These are the key things. Generally, we don't go beyond 2 millimeters anterior to the inferior rectus, and then when you're spreading out the muscle, do not spread it laterally too much. Okay, you should spread it you need to bunch it up. So you need to create a J kind of configuration. And so if you try to go lateral to the inferior rectus, you're going to spread the muscle, and then you're going to cross an anti-elevation. So as much as possible, try to be closer to the insertion, 1 millimeter anterior to the inferior rectus, temporal part of the inferior rectus insertion, or 2 millimeters. Mims and colleagues have gone up to 3 millimeters also. Depending on the DVD, you tend to do that. But pretty much the main thing is, you need to kind of bunch up the fibers and do not spread them laterally too much, so that you won't land up with an anti-elevation. And then you do bilateral symmetric, so that you don't get an anti-elevation syndrome. If you have a DVD with inferior oblique overaction and you have asymmetric inferior oblique overaction, do symmetric on both sides. It will take care. But you do it in one eye, then you will have anti-elevation syndrome. And sometimes, if you do a bilateral inferior oblique anterior transposition for a DVD with inferior oblique overaction, you're going to take care of both of them at one go. But then make sure that, if you don't do what I said, do bunch it up, don't spread it out laterally, then you're going to cause, as the eye go up, they just kind of diverge out. And then they got a significant V in the up gaze. And then again, it will cause, contralateral, the obliques to go up, and so on and so forth. But sometimes, I don't know, Parth and Savlin, sometimes, as the eye goes up, you can see some kind of a lump kind of thing on the lower lids once you do an inferior oblique anterior transposition, especially if you go 2 millimeters or 3 millimeters. That thing just persists for a long, long time. But these are, I think, the factors which you need to take into consideration when you're doing the anterior transposition.
Thank you, Dr. Rao. We actually did see this.
Sorry, Sabine, I think because of time, I'm going to ask one more question from the audience, because they're very important to us. And the question is, does traction test have a place in anti-elevation syndrome pre-op? And maybe Dr. Paulo can help us with that one.
Yes.
So the question again was,
yes,
test have a place?
Yes, the force reduction test is so important in this case to evaluate the presence of restriction or not. And in this case, Sablin told us that the force reduction test is negative, not Sablin? And
yes,
there is not restriction at the base. So I'm thinking the surgery, the anterior transposition of the inferior oblique is too much surgery for this patient. Because in the primary position, the deviation is small for this kind of surgery. So I would have performed a recess of the inferior oblique, not the anterior transposition. That's my opinion.
Thank you, Dr. Paulo. Sabine, in terms of, because of time, I think if we can carry on with the presentation.
Thank you. I would just, I think the third question that I had, the treatment options, the panel has already answered that question for me. And as my mentor says, that many roads in strabismus lead to the same destination. So what we did was, we actually did a forced suction test, which was negative. He was willing for the surgery of the other eye. He had a hypertropia in all the three gazes, in up gazes, which was equal in adduction, abduction, as well as in the primary gaze. We decided to do a posterior fixation suture for the right superior rectus under peribulbar anesthesia, a short clip of the surgery where we hooked the superior rectus through one incision, and I have made another incision at around 15 millimeter from the limbus and have tethered fibers of the superior rectus and sutured them to the sclera. The same thing was done on the other side. Postoperatively, he did not have a diplopia in the up gaze, and he had equal elevation in both eyes. We chose the superior rectus primarily because he did not have a hypertropia in the primary gaze, and the posterior fixation suture will not cause a deviation in the primary gaze. and the upgaze diplopia was eliminated. We did see this at the first follow-up and then 4 months later when he was diplopia free. So that's about it. That's what I wanted to offer. My learning points from the case was that different mechanisms could have caused this limitation in elevation. We could decide the procedure based on the choice of the primary position hypertropia. And as the panel has already stressed that anti-elevation can be avoided by inferior oblique insertion, never anterior to the inferior rectus. And as Dr. Rao has said, that there should be no lateral spread of the fibers. And sometimes we create a resection effect once we are disinserting the inferior oblique. And to my mind, that is also a point that once we are disinserting the inferior oblique, we should not dissect any fibers of the inferior oblique in order to avoid this anti-elevation. This has been reported to occur when we do everything all right as well, to the extent of 8% by Kushner. So these are my learning points, and thank you very much.
Thank you very much, Sableen. Great presentation. I'm sure we're going to have a little bit more discussion. Well, I think one of the things that you quickly went through on one of your slides was that this was done under peribulbar local.
Yes,
and
it was done.
When you're looking at the surgery, it's quite significant. So I'd like to ask the panel, how many people do this kind of surgery under local anesthetic? And any comments or experience? I want to hear from everybody, so I'm going to start with Dr. Shah.
Yeah, look, at the center where I work, very rarely do we do surgery under peribulbar anesthesia. Most of the surgeries I do are under general and including muscle relaxation, which is sort of a separate topic. I do some topical surgery for small angles, so I can do intraoperative adjustment. But yeah, generally not under peribulbar. So I think it's amazing that you're doing this surgery under peribulbar, and it just goes to show regional variations in anesthesia strabismus surgery. Great surgery.
Okay, and Dr. Guiaro, through your training, have you ever seen this done?
No, most of them, or I think all of them under general. Yeah.
I think peribulbar anesthesia is very common in our part of the world because of the volumes that we have and limited general anesthesia availability. So peribulbar anesthesia in a cooperative adult is often chosen. I do it all the time. So.
Okay, Dr. Matafsi, how about in Greece?
Anesthesiologists are not very common in Greece, but I have never attempted to do surgery under local. I mainly do strabismus surgery in children. And the only time that I used local was for a thyroid patient who had severe cardiac problems and was unable to undertake a general. And it was with great hesitation, but I did do it, and it turned out well. But I do admire you for attempting to go as far back in the globe as you have done and put sutures there. I think this must be very difficult to do. So well done.
And Dr. Polo?
I haven't got experience in local anesthetic. I operate my patients under general anesthesia. Is that my experience?
And Dr. Venkat, have you seen more of this because of geography?
Most of my surgeries are under general anesthesia. Rarely I've done under local anesthesia, especially other panel, my members, my co-members, who said that especially when you have a patient who's unfit for general anesthesia, then we do under local anesthesia. But I pretty much haven't done under local anesthesia as such, especially the Farden procedures, which is technically difficult. Farden, putting it especially on the superior rectus muscle is technically difficult, and then the superior oblique fibers keep coming there. So tethering it sometimes is, really takes time. Well done, Sableen.
Thank you, everyone.
I think that one was one of the questions that came through as well. Does the panel do the Farden or resect the same muscle? Dr. Polo?
Evelyn,
I
could you
would,
just stop screen sharing, Evelyn?
Yes,
Sorry.
I would do that. Thank you.
I would perform a recession of the same inferior oblique of the left eye. I would have a check where the inferior oblique is attached, and then I would have to be recessed to 4 millimeters behind the inferior rectus, the lateral border of the inferior rectus.
And does anybody have any opinions about other surgeries that could have been performed apart from these? Was there another surgical option for this case?
Yes, maybe operate the right eye with a small recession of the superior rectus with adjustable surgery, suture. But in this case, I think we have to resolve the limitation of the elevation that, in my opinion, was created by the anterior position. So we have to check this procedure.
In terms of the Farden versus the recess resect, I tend to do a posterior fixation suture for choosing one versus the other. And I tend to fix not directly to the sclera, but to the pulley tissue, which can be found all around the globe, which can be a little bit easier and safer, especially when you're trying to get really far back, as described by Dima.
Yeah, Parth, I just quick question. We have actually almost given up doing Farden on superior rectus.
Okay.
Especially, DVD was the one which we used to do, superior rectus Farden. But it's been shown that superior rectus, large superior rectus recession works much better than a superior rectus recess with Farden, especially the superior rectus muscle. So I think over a period of time, I think we have evolved into doing larger superior rectus recession, especially for the DVDs, rather than doing Farden. But in this particular case, if the anti-elevation was a factor there, then you have to kind of go and open up the inferior oblique and then kind of re-recess the inferior oblique downward. The other procedure you could do in this could be a minuscule right superior rectus recess. Mini recession of the right superior rectus, as what sometimes the Ken Wright was doing, mini tenotomies, on the table where they do. But that's one procedure, that's again a safe procedure to do, where you want to kind of get that field of gaze where the problem is there. So you could actually do a mini superior rectus recession on the right side.
So I'd like to thank Sevleen for this fantastic talk that generated some great discussion. I'd like to remind people now that they can answer the last two questions on the Menti code. And remember, the code is 2394971. And I'd like to just ask Ravi now to introduce our next speaker. And
thank you, Dr. Gas.
Thank you.
Sevleen, for a really nice case there. So I'm going to introduce Dr. Mina Matafasti. Sorry. So, and she's going to, if you can start sharing your screen, Mina.
Okay. Thank you. Thank you for giving me the opportunity to share this case with you and discuss management issues. I'd like to point out that I have no financial disclosures with any of the products shown later on. So this is a 4-year-old girl that brought in by her mom. She was previously followed up with a clinical diagnosis of aniridium, almost since birth. She has never had a genetic test done, and she was followed up with renal ultrasounds every 6 months and with sedation for intraocular pressure measurements every 6 months. She presents intermittent exotropia and doesn't wear any glasses, and this was a point of frustration of mom, who said she stumbles upon things, and can you do something better for my daughter? So this case, as aniridia is a panocular disease and affects all of the eye's tissues, does indeed show a keratopathy, which I was unable to photograph. This is a picture coming from a review paper. And she does have a partial aniridia. There's a little bit of iris seen. She had from the beginning bilateral cortical cataracts. No signs of glaucoma as yet, but definite optic nerve and macular hyperplasia at the back of the eye. So I thought that, first of all, given her diagnosis of sporadic aniridia, I looked up at the guidelines that oncologists dealing with renal tumors give for little children with sporadic aniridia, and it says that they advise that renal ultrasounds are carried out every 3 months from birth until the age of 5, and then they later on spread out to every 6 months or every year, unless you perform a genetic test and you're able to show that the genetic problem is only within PAX6 gene and not involving other genes in the area, like, for example, if you have a chromosomal deletion, in which case the highest risk for a Wills tumor exists, and then you have to do the 3-monthly checkup. So I thought this girl deserved this test, and although it was difficult for the family to pay, we managed to fundraise and get it done. It was an array CGH test that tests for the whole region of the chromosome, and it was shown that my patient had an interstitial deletion within 11p13 chromosome. This deletion includes gene PAX6 in this patient and does not include the nearby WT1 locus, which is responsible for the increased risk of Wilms tumor, in which case it was shown that we can exclude Wagner syndrome and we can save the girl from having to have the renal ultrasound every so often. I think this is an important thing to discuss, genetic testing in aniridia, and I pass on the question to the panelists, if you want to comment.
Yeah,
Okay,
look, I think, sorry, Ravi, go ahead.
Sorry, Path, carry on.
I think raise a great point here, Mina, because genetic testing, I think clinical diagnosis can be quite misleading sometimes. And yeah, although this patient has sort of partial aniridia, there can be other things that it could be. And I've certainly seen one patient recently who was diagnosed with aniridia and presumed to have a PAX6 mutation, but actually turned out to be a FOXC1 Axenfeld-Rieger syndrome. And there are other diagnoses which may present differently, such as an ACTA2 mutation causing congenital mydriasis. They tend not to have nystagmus and the other features, but I think it's important to make a diagnosis, and as you advocated for your patient and got the funds to do genetic testing, I think that was very important. As you said, knowing that it's not increasing the risk of Wilms tumor, you can avoid unnecessary testing. And also in aniridia, the type of a genetic defect has been shown to correlate with the severity of ocular surface disease. So depending on whether it's a coding or a non-coding or a missense mutation. So I think not only does it sort of confirm the diagnosis, it has severity implications as well as treatment implications. So as we know, there's adalurin for nonsense mutations. So I think it's critical to try and get genetic testing. I'm surprised that some of my colleagues, even in a place like Sydney, Australia, don't order genetic testing for these sorts of cases.
Thank you, Path. So we've had one question that's come through the web link. What is your opinion on the use of optical aids in aniridia cases? I think we're going to discuss this in a bit more depth later on in the talk, so I'll leave that parked on the side for now. Are there any other comments on genetic testing in PAX6 mutations in aniridia cases?
Just for just like a take-home message, and it's reiterating the same. For these patients, genetic testing is a must, because if you cannot get the genetic testing by whichever reason, then it is a must again to do renal ultrasound every 3 months, because you are not able to exclude whether the patient has a Wilms tumor, and it is a very fast-growing tumor. So genetic testing is a must, and if not, renal ultrasound every 3 months, and if possible, genetic testing, and then the protocol as Mina said before.
Okay.
This is what needs to be done with the insurance companies about the paying for genetic testing. Seems that they're happy to trickle money into seeing a child every 3 months with a sedation and intervention, and the real cost of people taking time off of work, coming to appointments. So I don't think it's a matter of money, because they're paying money out, but it's also a matter of kind of educating that the genetic test will actually stop money being used in the future. I don't know if there's anyone.
So, Mina, do you want to carry on?
So to describe this girl a little bit more, she had large amplitude, low velocity nystagmus. Unfortunately, I was unable to do extraocular muscle recordings. She did have this intermittent exotropia, and I was able to measure her visual acuity with Cardiff cards at 1 meter. This is acuity expressed in logMAR, and I used a semi-transparent cache cover for measuring uniocularly to account for the nystagmus that she had. I was also able to refract her, and this showed a moderate amount of hyperopia and astigmatism, quite symmetrical. And I decided to prescribe glasses for her, but to undercorrect her spherical hyperopic error, to not exaggerate her exotropia too much. So here she is with her glasses on. And at this point, I would like to discuss refraction in an aniridic child, because when it comes to having a patient with nystagmus who may have also cataract and may also have blepharoptosis, and in some cases, a slightly subluxated lens that may or may not be appreciated clinically. There's a number of challenges involved here. First of all, I'd like to ask if anyone thinks that cycloplegia is unnecessary or necessary, given the certain amount of iris that is not there. Then, do you think that refraction is better with the child awake or better under sedation? Do you trust the measures that the autorefractometer gives you if the child is able to cooperate with that? And then finally, would you opt for partial or full correction in this context?
Maria, do you want to come in there and talk about your experience with aniridia?
Yeah. So to the question, is cycloplegia necessary? The answer is yes, because the ciliary muscle is the one that is involved in the refract. We need to make sure that we paralyze the ciliary muscle, whichever that's the first response. The second one, I think they are both complementary. So the benefits of doing refraction in the office is that you know whether you are refracting on axis, and you can know, you can get to know which part of the retina is a child fixating with. So that is something very important to take into consideration. The benefit of examination under anesthesia is that the setting is less challenging, as Mina was explained before. do you trust the autorefractometer? For me, it's the initial, it gives me information. I usually start with, if I'm given the autorefractor measurements, I usually start with more diopters than the one that is given in the autorefractometer. I usually do the skiascopy with the bar, and then I usually adjust the refraction on top of the glasses. And regarding partial versus full correction, I say I would adjust the prescription in order to try to so that the squint is less destabilized with the refraction I give, and also I need to see whether it helps the VA of the patient and the degree of the nystagmus. Those are my answers.
Okay. Does anyone else on the panel have experience using an autorefractometer with nystagmus patients? Because I think my experience is autorefractometers with nystagmus don't seem to work so well. What does the rest of the panel think?
Oh, look, I don't think they're very helpful in these cases either, Ravi. I don't tend to use the autorefractor that much in children generally, but especially in these more complex cases with nystagmus, I think they can be quite misleading at times. And just in response to the questions here on the screen, I think cyclopegia is definitely a must. So there's a few papers that document the absence of complete cyclopegia under general anesthesia, even with muscle relaxation. And that's related to the muscle relaxants given, such as succinylcholine, providing they work on skeletal muscles and on nicotinic acetylcholine receptors, whereas the sphincter pupillary muscle has smooth muscle and muscarinic ACH receptors. So general anesthesia does not cause cyclopegia, even with systemic muscle relaxants. I find refraction easier in the awake patient generally. The other couple of issues in addition to what Conchi mentioned already about anesthesia is the presence of a speculum. So if you use a speculum, that can affect the refraction, especially the astigmatic component, as well as corneal desiccation that can occur, refracting under general anesthesia. And I actually find analytics quite hard to refract generally because of the large red reflex. So it's important to focus on the very central reflex, as the peripheral lens is also can cause a different refractive index and a different reflex of light, as well as when you're refracting through the edge of the lens, and then you've got a complete aphakic component as well. So I find these refractions actually some of the most challenging ones to perform.
Okay, and can we just go back to the question that was asked earlier? So the question on the use of optical aids in aniridia cases. Maria?
So the question is, well, I don't know whether I remember what the question, but anything that can help the child to improve the visual acuity, is welcome, basically.
Yeah, I think from my point of view, I think one thing that might hinder the use of optical aids, and I think this child is maybe a bit young, but if the patient has a head posture, if they have a null zone and they're adopting a head posture, are the glasses really going to be as optimized as we can get them? There is some use of some evidence on the use of contact lenses. Maybe they achieve better outcomes using contact lenses, but I guess this child might be a bit too young for contact lenses.
Okay. I guess another issue, Ravi, that comes up with contact lenses, which Mina might discuss later, is the ocular surface disease. So unfortunately, in nystagmus, contact lenses generally can sometimes dampen the amplitude of nystagmus, but in these patients with aniridia who have limbal stem cell compromise, that can be a problem.
Okay,
This comes up actually. So
yeah, shall we move on, Amina?
move on. So at follow-up, this is just a 6-month follow-up. The girl was freely alternating. Exotropy is pretty much constant. She prefers her left eye. And mom reports that she doesn't really like her glasses. She puts them on, puts them off, takes them off. And at this point, age 4.5, I measured her visual acuity with case pictures test at 3 meters. And here she shows that she doesn't have such a good vision after all, but she does get some gain, especially in her left eye with the glasses on. Having worn her glasses on and off for 6 months and repeating the cycloplegic refraction, she now shows a greater amount of spherical error. And at this point, I was in the dilemma of changing her prescription, increasing the amount of sphere in her glasses, and whether or not I should try and treat her amblyopia, which seems to be in the right eye, with a patch or with atropine, taking into account that she does have nystagmus. Now, I decided against both of these options because she wasn't compliant with the current glasses in the first place. But maybe we can discuss this later on, what your opinion is on. I don't think there is a very, very clear-cut, correct way to go ahead. A very important issue that I discussed with the family was her photophobia. I did advise a wide-brimmed hat or cap, and I did encourage them to try different filters for her glasses or even photochromic glasses. But I wasn't sure as to whether specific filters were indicated, especially for screen use, or if filters were indicated for the car windows, as mom asked me. About contact lenses, I think it is important to bear in mind that aniridic patients have a compromised ocular surface, even if you can't see it clinically. There is conjunctival tissue that travels across the cornea, even in the very early stages of keratopathy, and the corneal epithelium is compromised. So to fit a child with a contact lens that sits on the cornea, I don't think it's a good idea. I find that a lot of ophthalmologists advise contact lenses with artificial iris, and the only evidence that I found in the literature for a lens that could be fitted for an aniridic patient was a scleral contact lens that actually sits further away. It's a larger diameter lens and sits on the conjunctiva, on the sclera, if you like. And interestingly, there is a case report in the literature of such a lens, a PROS lens, being fitted in an adult patient who had, as you see in the pictures in the left, a moderate to severe keratopathy, very symptomatic. And 3 years or 5 years down the line, this was reduced in severity with the use of a presence. Someone is to wear a contact lens in the presence of aniridia, I think they should be, the scleral lenses should be the only ones used. Another very important issue that I had to stress every time the child came back to follow up was prophylaxis for keratopathy. And this is the use of artificial tears or gels and lubricants. I don't know if there is, not to my knowledge, any evidence to support one substance in favor of against others, but it's important to use them as often as possible. And it is logical to use preservative-free products because it's a chronic use in a compromised ocular surface, and preservatives are toxic. We know that, to the epithelium. It's also very important to try and see if the lids are inflamed. In a child, it's difficult to address meibomian gland dysfunction with compresses and lid hygiene, except for perhaps doing a little bit of massage during their bath in the evening. But it is easy to support the lids with oral intake of omega-3 products, either artificial or flaxseed oil. And this has been shown to help with blepharitis, and blepharitis has been shown to exist and exacerbate ocular surface disease in anuritic patients. In more advanced stages, the use of anti-inflammatory drops or autologous serum eye drops, punctal plugs, cyclosporin eye drops have been used and are to consider when perhaps more into the second or third decade of a patient's life as the keratopathy advances. Now, for this girl who's now 12 years of age, at this 8-year follow-up that I've had with her, she never really wore her glasses except for near work. For some reason that I failed to understand, at age 8, she changed dominance. She prefers to fixate with her right eye ever since. And her vision has been around 0.6 logmar in that eye. It's worse in the left eye. Her near vision is a little bit better because she holds the chart or the book closer up, and she uses magnification of her glasses to read smaller figures. She has never presented so far signs of glaucoma, and her cataract is unchanged. And her keratopathy has gradually progressed to stage 2, that so far has no symptoms with it. She attends normal school and is fully functional, but I must say this is another issue with anuritic patients. She starts to feel bullied when she's wearing sunglasses in classroom and even her photochromic glasses, and she tends to want to leave them out and asks for contact lenses now. She's not so cooperative with artificial tears anymore because she's in her early teens and everything is a no. Very recently, we were able to image her macula with the posterior segment OCT. And as you can appreciate, there's no foveal pit in both eyes. Here on the right bottom side, this wriggly surface is an artifact because of her nystagmus. And I think this is another important issue to discuss, the role of OCT in aniridia, both for posterior segment imaging and anterior segment imaging. These are pictures from another patient. And maybe I will hand over to Maria to comment on that and discuss perhaps prophylactic corneal surgery that has been suggested and done by many.
Thank you very much, Mina, for bringing up these didactic images. I'd like to make 3 points. The first one is that we need to answer 2 questions with these children, as we know that a proportion of them may develop glaucoma. The first one is whether they have or not glaucoma, and the second one, basically that's the first one, and the second one is if you have a clear cornea that allow you to perform gonioscopy. Why is this important? Because if you have with these images, we can see that the mechanism that produces the glaucoma in these children is the anterior rotation of the iris stump, and then it blocks the trabecular meshwork. If the children doesn't have glaucoma and the iridocorneal angle is still open, then you can perform prophylaxis goniotomy. Importantly, if the child has glaucoma and the iridocorneal angle is closed, then you may want to, or you would need to consider tube surgery. Now, having done tube surgery in adults here in Oxford, and having seen also these children, and also being familiar with different types of tubes like Paul, barbelled, pars plana tubes as well, I'd like to mention like 3 things that should be taken into account when you are going to perform tube surgery in these children. The first one is that because of the keratopathy and the limbal cell deficiency, you would need to do a limbal-based incision in order to preserve for these children, basically. And secondly, you need to know which is the actual length of the child, because that will help you to choose the device that you will put in these eyes. Because what you don't want is a very large device that will be damaging the optic nerve. However, these children usually tend to develop glaucoma when they are like a little bit older, so you wouldn't expect a very short eye, but that is something to have in mind. And they don't have ophthalmic eyes, so when you are placing the tube in the anterior chamber, importantly, it shouldn't be too long because you can cause endothelial decompensation. It cannot be too short because they can have retraction when they grow. And in terms of the orientation of the tube, it shouldn't be radial as we do in adults. It should be more tangential. Why? Because you don't have iris protecting the lens. So if you leave it radially, then what you are risking of this child developing cataract, and then you have another problem to all of the ones that they already have. So also we need to be careful with the cautery, and if you can avoid mito, then better. And just to finish, I'd like to ask a question to the people who are watching, and maybe they can post their answers in the chat, because as we know, these children tend to have fibrosis syndrome. And I'd like to ask my colleagues who are putting tubes in these patients if they encounter a higher rate of encapsulation of the blood, and if they do, how do they prevent it or treat it? Those are my comments. And I think, Ravi, it would be interesting also to know, well, I think that after this slide, there's some interesting information about OCT in the posterior segment. So, Ravi, would you like to comment on the use of this?
I will definitely comment on this. Just before we carry on, we have online attendees from over for almost 100 countries now, including Honduras, Iran, Pakistan, Mexico, Guatemala, Cyprus, Vietnam, Malaysia, and Jordan. Thank you everyone for joining. Please don't forget to answer the Menti questions as Alki talked about earlier. The code is 2394971. So, Parth, do you want to just mention, talk about the question that Maria just posed about the glaucoma complications?
Yeah, sure. Look, I think everything that Conchi mentioned was, I would agree with in regards to tube surgery. One thing that often can come up is the presence of glaucoma early in infancy. And my mentor, Ken Nischel, taught me that temporizing diode laser can be quite helpful in those cases in order to avoid putting in a tube too early and the complications associated with that. So if we can delay the tube surgery in later infancy, then that would be ideal. And yeah, look, I'm fortunate to have access to the anterior segment OCT in the center where I work. So able to image the anterior segment quite well. The other thing that can also help is an ultrasound biomicroscopy or high frequency ultrasound, which can give really nice images of the anterior chamber angle. In regards to prophylactic goniosurgery, I haven't had any patients or experience with that, but certainly would be something that I'd be willing to do if there was a patient with aniridia and this angle configuration.
Okay, thank you. So just a few points to pick up on. So before I start talking about OCT, we talked a little about amblyopia and whether we treat the amblyopia. My experience of treating patients with nystagmus and with nystagmus and amblyopia, it depends what type of nystagmus they have. If it's a latent nystagmus, there is some evidence to suggest that when you cover one of the eyes, the nystagmus amplitude after a while does dampen. So the amount of occlusion therapy you'd need to administer, you'd maybe want to increase. However, that said, there isn't much, as far as I know, there isn't any documented cases of manifest latent nystagmus with PAX6 mutations. Doesn't mean to say it's impossible. Does anyone else have experience of treating amblyopia in nystagmus on the panel?
I have
Ravi,
experience in.
I think, yeah, Ravi. Sorry. Go ahead, Claudia.
Sorry. I have experience in amblyopia with the patients with nystagmus, and the occlusion is a challenge because the occlusion worsen in the nystagmus. So we can occlude the eye, the fixing eye with a translucent patch. And in all that, this patch can cover all the eye, and this have to be translucent, not with total opacification. And we indicate visual stimulation, early visual stimulation for these patients. And this kind of stimulation is binocular too. But the other kind of treating the nystagmus in these patients is the sectorial occlusion over the glasses. The sectorial occlusion have to be translucent too, and the occlusors has been used over the glasses in the same direction of the gaze, in attempt to modify the head tilt to another side. And the amblyopia in this patient is a challenge because they has a multifactorial causes, but we can try, and then we see the results.
Thank you, Claudia. So I'll just move on to some of the work that is happening in relation to the use of OCT in infants. So over in Leicester, we've used the handheld OCT quite a lot in patients with nystagmus. And in Oxford, we're using it. We're using the Heidelberg Flex in children. There was meant to be an image there, but it's not been put in there. And the implication of this is quite profound. It allows us to look at the disc. It allows us to look at the structure of the fovea. A recent study by one of my colleagues, Dr. Rufai, has looked at how we can predict vision. So they took a cohort of patients with nystagmus under the age of 3, did OCT scans on them, and then followed them up 2 years later and graded foveal hyperplasia against visual outcomes prospectively. And you know, patients with grade 4 foveal hyperplasia had a mean prospective vision of 1.0 logMAR. So Mina, your patient has done tremendously well, having grade 4 foveal hyperplasia to end up with 0.6 vision is a good achievement for her. And just moving on to the next slide. If you don't have access to technologies like handheld OCT and articulated OCTs like the Flex, you can use Flying Baby, which we've proven over in Oxford. Yes, this is in slightly smaller children, but it is a method that we have used and proven and works. So yeah, and if we just move on to the next slide. So, the question of glaucoma, do we have a normal optic nerve? Well, we have looked at this over in Leicester. We have categorized what and classified the normal optic nerve head in this publication. And there's also a video attached. If we could play that video, it just tracks the changes of the optic nerve from birth up until the age of 12. So you can see the cup becomes shallower, the rims become fuller, and we have all of these all of the figures to classify what normal is in a pediatric cohort. So, coming back to Maria's point about glaucoma and monitoring changes at the optic nerve head, we can do that using OCT. And if you have a deeper, more excavated cup, thinner RNFL in some of these patients with these complications, we can quantify that.
Thank you, Ravi, for showing the
everybody.
job that you are doing.
Yeah, sorry, Maria, I've just got one question. In terms of amblyopia therapy and refractive correction, I mean, in some of these children that do have slight head turns, Ravi pointed out that that they don't appreciate the glasses that melt because of the orientation of the eyes. Is there any scope or possibility of decentralizing the maximal focal power within the glasses to suit their head turn?
Okay, I've not seen that being done, but it's certainly a good suggestion. One other issue may be whether trying to do eye muscle surgery to put the null point back into center to try and get them best corrected in the glasses. I think in this case, the refraction was fairly symmetric between the two eyes, and there wasn't that much astigmatism, but often in the cases where they're using a head posture or a head turn, I tend to give the spherical equivalent refraction rather than the astigmatic component, as it can actually lead to a slightly different correction in a different gaze position at the periphery of the lens. Yeah, in relation to the amblyopia as well, in this case, I think the near vision demonstrated that it was fairly symmetric between the two eyes. So I suspect that the distance vision disparity may have been largely refractive more than anything else, as the near vision was fairly symmetric between the two eyes. And agree with the earlier comments about treating, as a general rule, treating amblyopia, if it is present in patients with nystagmus, that patching in days per week, not hours per day. There's a paper by Herb Simons in 1989 with eye movement recordings, which demonstrated that it does take time for the latent nystagmus to dampen and for amblyopia treatment to actually take effect. So patients with nystagmus, if we're doing 2 hours of patching per day, it's almost useless really, because they haven't really dampened their nystagmus yet and started fixing with the poorer seeing eye.
Is you'll also get a prismatic effect as a result of not using the optical center of the lens, of changing the prescription and inducing a prismatic effect. Is that going to be beneficial or not? It's not something that I've come across.
Okay, so we're getting close to the end of the discussion. We're going to go through the Menti questions at the beginning, but I think Ravi maybe he's going to go through and ask everybody for one of their final comments, and then we'll go through the Menti questions.
Yeah, so we've had a couple of questions from YouTube. I think we can probably direct this towards Maria. Apart from everyday lubrication, is there anything more that we can do to keep the cornea clear?
Maria, you need to.
You're muted.
Sorry. Yeah. So yeah, I'd like to answer that question. 3 points. The first one is that until we find something to treat the cause of the origin of the problem of these children, we will be just dealing with effects. We will just treating its effects. So second thing is the minimally invasive we are, the better. And the third one is in order to treat the aniridia-associated keratopathy in these children, there are different scales, and according to the degree that the patient has of the keratopathy, there are different treatments. So if cornea is here, lubricants are enough. If you have a mild to moderate keratopathy, then you will want to serum, autologous serum. You will want to move to autologous serum. If you need to do some panos removal and therefore you need to implement the corneal healing, then you might want to do an amniotic membrane transplant. And then we have, when we have children with very severe keratopathy, opaque corneas, then there are some treatments, they are more aggressive. We need to balance the risk of fibrotic syndrome, and there are cases where the insertion of Boston keratoprosthesis in those children with lens extraction, and also including tube surgery in the same procedure, because these children, if you do a Boston keratoprosthesis without that tube, they will develop a glaucoma, and you need to do a tube surgery simultaneously with the insertion of the Boston keratoprosthesis. That's like the end stage of the disease. But it's interesting, one interesting thing is that there are different grading scales. There is no clear agreement between them, so it would be also desirable. But again, we are still dealing with the effects of the disease, and there's still no treatment to cause the origin of it.
Thank you, Maria. We're running short on time, so I'd like to thank Mina for such a brilliant presentation and a very interesting case.
Thank you.
I'll just call Alkin to go through some of the participation that we had from the Menti, the response from the Menti questions.
Yeah, so we've had a fantastic response with the Menti questions. So number one, where around the world we are, we've had over 100 countries, a large contribution in Asia, Europe, North America. Number two, male or female, and this is great, 83% female today compared to the 70% male. What do you do? Large number of ophthalmologists, orthoptists. Number four, how old are you? Largest proportion, 41 to 50-year-olds. It's good to see some younger people, 31 to 40. And we've got some retired people over 60s as well. So a big range of people at the beginning of their careers and falling off at the other end as well. At the place you work, do you have residents? Yes, 35%. Both fellows and residents, 39% again. Neither fellows or residents, 26%. So a lot of people kind of working on their own. Number seven, do you have the facilities to get good 9-gaze pictures? Fantastically, 87% of the people said yes, and 13% said no. So good documentation of 9 positions of gaze. With regards to is cycloplegia necessary? 61% yes, 22% no. That was interesting. Number 9, in aniridia, is refraction better in the clinic or at an examination under sedation, under anesthesia? 35% in clinic, 26% said under anesthesia, and then a quite large group, 40%, were unsure. And we've answered some of those questions in the presentation. Number 10, do you use artificial tears or lubricants in aniridia? 65% yes, not sure in 10%, and then no in 26%. So again, the majority leading to lubricants. Do you have access to formal eye movement recordings? 50% said yes,
Wow.
5% said no. So that's surprising to me, because I usually find that lots of places don't have good eye movement, don't have the ability to do eye movement recordings.
Yeah.
Number 12, now having heard the talk, would you consider using a peribarbular nerve block as a topical anesthetic? 24% said yes. 76% people said no. They're still a bit worried about that. So hats off to you, Sylvain. And number 13, what according to you was the best part of the webinar? And it's one of those word doodle things. A large proportion of the people said discussion. So that's a reoccurring theme. Everybody likes the way that the cases are discussed. We talk about things that we don't really ask usually. The cases, they love the 2 cases. New faces. I think we may all be new faces to some of this, and many other things. So I'm just going to hand back to Raveen then. Ravi, you're still muted.
So thank you everyone for joining. I'd just like to thank Akila, who's worked very hard on kind of coordinating things for us, and Daryl, he's been working in the background on the technical side of things, and we've got some certificates that will be, and just one last,
taking a bit of time. There you go. So if people need attendance or participant certificates, please go to program@WSPOS. I think we should all remember that we're also able to continue to register for 2020 Connect. There's some fabulous talks. I've gone back multiple times and listened to some of these. Ravi, do you want to just mention the new webinars that are coming up?
So we've got a few webinars coming up. In January on the 9th, wide field imaging in pediatric ophthalmology. On the 23rd of January, ocular surface disease in children. On the 30th of January, early onset esotropia. 6th of February, we've got a webinar on uveitis. We've got another grand round on the 20th of February. On the 21st of February, on Sunday, we have the WSPOS Strabismus Hall of Fame. Telemedicine and ROP on the 6th of March. On the 20th of March, thyroid eye disease. 27th of March, virtual strabismus and wet lab part 1. April the 3rd, allergic conjunctivitis. April 17th, retinoblastoma. Then a grand round again on the 24th of April. Session on nystagmus on the 1st of May. On the 15th of May, malignancies and the pediatric eye. Ocular pathology on the 29th of May. On June the 5th, updates in ophthalmology, and on the 19th of June, virtual strabismus wet lab part 2. Okay, and for everyone that's new and not following us on social media, please join our Facebook page and visit our website. Membership is free. And again, thank you to Akila and Dare. This presentation was recorded and will be available on YouTube.
Okay, so just quickly before we all have to sign off, just one last comment from everybody. Dr. Venkat.
Yeah, it was wonderful to have those 2 cases and then have a wonderful discussion on both of them, and with participation all over the world. It looks pretty exciting.
Thank you. Dr. Paulo?
Thank you for the invitation and the opportunity to be here, and congratulations to the speakers for these great cases.
Thank you, Dr. Shah.
Thanks very much for the invitation. Had a lovely time, learned a lot. myself, and it was great to participate in the discussion. And hopefully you'll keep it at the same time and no later, as it's 2 a.m. here in Sydney.
Thank you, Dr. Paul. Dr. Guiaro?
Yeah, thanks for the invitation. It's been a great experience. Thanks for the people who asked questions, and hope everyone is well and safe at home.
Okay, and finally, and mainly just to thank Slovene and Dr. Mina Matafsi for some great talks that produced a lot of discussion. And a big thank you to NTOD for supporting us and putting this together. I think that's it.
Thank
One
you so
another
much.
grand rounds.
Bye-bye.
Bye-bye.
Thank you all. Thank you. Thank you very much. Yeah. Thanks.
Thank you.
Thanks.
Bye-bye.
Thanks.
Thanks, everyone.
Bye.
Bye-bye.
Thanks.
Bye.
Thanks.
Thank you. Bye.
Bye.